is my delight to introduce today's speakers to the Cornell Center for Health Equity seminar series. Today we have Alina Boltunova and Robert White, who are from our Department of Anesthesiology at Weill Cornell. Alina is an anesthesiology resident who completed her residency with us here at Cornell and graduated from the NYU School of Medicine. And I guess her mentor is safe to say is Robert White, who is an assistant professor of anesthesiology and the Van Posnack Anesthesiology Research Scholar at Weill Cornell. Dr. White completed his postgraduate training at Weill as an obstetric anesthesiology fellow and anesthesiology resident. He received his MD with special distinction for clinical investigation at Albert Einstein College of Medicine, where he also obtained an MS with distinction in clinical research methods. He graduated from Cornell University with a Bachelor of Science in Biological Sciences with a concentration in neurobiology and behavior. He's published extensively on social determinants of health and their impact on perioperative care and on differences in maternal obstetrical care and delivery outcomes. Today, they will be talking to us about diseases of despair, opioid use disorder, and perioperative outcomes. Thank you very much, and we very much look forward to your talk.
Hi, everyone. Again, I'm Alina Boltunova. I'm one of the anesthesiology residents. And my co-presenter today is Dr. White. He's an assistant professor of anesthesiology. I think he's just having a little bit of technical difficulties with the sound. So I'm just going to get started, and hopefully he'll be able to join us shortly. But today we're going to be talking about diseases of despair, opioid use disorder, and perioperative outcomes. So this is Dr. White's disclosure information. He has no conflicts of interest to report. And I have no disclosures or conflicts of interest to report. So I just wanted to start by talking a little bit about opioid use disorder. So opioids are commonly used as pain medications for their analgesic properties, but they can also cause euphoria and sedation. And opioid use disorder includes the misuse of these prescription medications, as well as their diversion and the illicit use of heroin. And opioid use disorder can be thought of as a chronic and relapsing disease that can have high associated morbidity and mortality. And opioid use disorder is one of our diseases of despair. So diseases of despair are a group of behaviorally tied medical conditions that are related to social and economic conditions. So they increase when the outcome is bleak. And they include 3 disease types, which are substance use disorders, suicides, and alcohol-related diseases. Diseases of despair and the resulting deaths of despair are the highest in the Appalachian region. And in 2015, the mortality rate of diseases of despair in Appalachia was 37% higher than in the rest of the United States. And their prevalence started increasing around the turn of the 21st century, first among working class white Americans starting in about 2010. And however, this was followed shortly by an increase in mortality for Hispanic Americans in 2011, and then for African Americans in 2014. Diseases of despair have gained media attention because of their connection to the opioid crisis. And in 2018, about 150,000 Americans died from these causes compared to 65,000 in 1995. And this is the Appalachian region So it's a large region that stretches all the way from New York down to Mississippi, Alabama, and Georgia. And disease of despair are different from disease of poverty because poverty itself is not the central factor here. And groups of impoverished people who have a feeling that their children's lives are going to get better are not as affected by disease of despair. So instead, this group of people believes that the future will not get better. It seems to affect white people more than racially disadvantaged groups, possibly because these groups may be in a better economic position than their parents. So moving on to opioid use disorder, one of our diseases of despair. So in the United States, about 100 million people are believed to suffer from acute or chronic pain in any given year. And unfortunately, patient exposure to opioids for the treatment of pain has created opportunities for opioid dependence. So these are the DSM-5 criteria for the diagnosis of opioid use disorder. It's graded on severity based on the number of symptoms that the patient presents with. And these symptoms include taking opioids in larger amounts or for longer than intended, being unable to cut down on opioid use, spending a lot of time using opioids or recovering from their effects, having cravings, being unable to fulfill obligations at work, school, or home because of opioid use, or continuing to use opioids even when it causes interpersonal problems, continuing to use them even when it's physically dangerous, and also exhibiting tolerance and withdrawal. So in the US, opioid use has surged since the late 1990s and has since reached epidemic proportions. In 2018, it was estimated that about 10 million adults misuse prescription pain relievers, and an additional 800,000 used heroin. So the national prevalence of opioid use disorder has ranged from about 0.7 to 0.9% in recent years, meaning that about 2 million Americans are affected. And the rates of opioid misuse have decreased slightly from just under 5% in 2015 to just under 4% in 2018. And these are just some notable numbers about the opioid epidemic. So over 130 people die every day from opioid misuse, and about 48,000 die every year. 11 million people misuse prescription opioids, and approximately 886,000 use heroin. So this chart demonstrates national opioid overdose deaths. And you can see that deaths have surged since the late 1990s, and they appear to have plateaued in the past few years at around 47,000 per year. And these are the overdose deaths by type of opioid use. So as you can see, opioid overdose death rates from synthetic opioids have recently overcome that of commonly prescribed opioids, and heroin deaths have surged during this time as well. So as we shift to thinking about opioid use disorder in the operative setting, past studies have shown that patients with preoperative opioid use disorder have worse outcomes after surgery. And some of these outcomes include higher rates of hospital readmission, more postoperative complication, longer hospital lengths of stay, and higher total hospital charges. However, these previous studies have been limited by small and single institutional data sets, and also a limited number of reported outcomes. So we conducted retrospective cohort studies using data from a large administrative database, the Healthcare Costs and Utilization Project's State Inpatient Database, or the SID. The SID is managed by the AHRQ, or the Agency for Healthcare Research and Quality.
You need people in the audience.
Yeah.
This database data from 5 states: California, Florida, and New York, Maryland, and Kentucky for the years 2007 to 2014. And we have surgical cohorts, which included CABG and valve surgery, the 15th and 20th most common surgeries. And our other surgical cohort was the abdominal surgery cohort, which included appendectomies and cholecystectomies, which are the 11th and 6th most common surgeries. So data extracted from each of our patient records included demographic information, including age, gender, and race, patient insurance type, meaning if the patient was privately insured or publicly insured, residence and quartile of median state household incomes, hospital volume quartile, admission and discharge dates, discharge disposition, as well as present on admission comorbidities. Our variable of interest in these studies was present on admission opioid use disorder. So a patient who already had opioid use disorder prior to surgery. And our outcomes of interest were in-hospital mortality, hospital readmission at 30 and 90 days, hospital length of stay, total hospital charges, and postoperative complications. So starting with our abdominal surgery group, it was divided into the appendectomy cohort and the cholecystectomy cohort. Our appendectomy group had almost 500,000 patients, of which 0.3% had opioid use disorder. And our cholecystectomy group had almost 800,000 patients, of which 0.5% or almost 4,000 had opioid use disorder. And in both of these groups, patients with opioid use disorder were more likely to have the following characteristics. So they were more likely to be younger, more likely to be male, Caucasian, non-privately insured, meaning insured by Medicaid or Medicare, and to have certain medical comorbidities, which included pulmonary disease, liver disease, HIV/AIDS, and psychiatric disease.
Where's the carrots?
So
Whatever.
these are our unadjusted outcomes of patients with and without opioid use disorder in the appendectomy group. So as you can see, patients with opioid use disorder had significantly higher rates of in-hospital death, 30 and 90-day hospital readmission, and certain pulmonary and infectious complications. And these are the outcomes of our multivariate analyses adjusted for confounders and hospital level clusters. So, sorry, I jumped ahead a little bit. So these were outcomes for patients with and without opioid use disorder in the cholecystectomy cohort. So unlike in the appendectomy cohort, patients with opioid use disorder did not have higher rates of in-hospital death. However, they did have higher rates of 30 and 90-day hospital readmission, and also certain pulmonary and infectious complications, just like in the appendectomy group. So these were the results of our multivariate analyses adjusted for confounders. So in both groups, appendectomy and cholecystectomy, patients with opioid use disorder had higher odds of postoperative complications, including pulmonary and infectious complications, 30 and 90-day readmission, longer length of stay, and total hospital charges. However, only patients in the appendectomy group had higher odds of postoperative mortality. And moving on to our cardiac surgery study, this again consisted of a CABG group, a coronary artery bypass graft group, and a valve surgery group. So our CABG group had almost 400,000 patients, of which 0.6% or about 2,000 had opioid use disorder. And our valve surgery group had almost 200,000 patients, of which 1% or 2,000 had opioid use disorder. So we do see a higher rate of opioid use disorder and in the valve surgery group. And interestingly, it's known that there's been a large increase in the rate of drug-associated endocarditis, and thus the number of infective endocarditis valve surgeries performed in the US. And also, we know that endocarditis patients with opioid use disorder tend to be younger and healthier compared to those without opioid use disorder. But in both of these groups, patients with opioid use disorder were more likely to be younger, African-American, non-privately insured, and also to be in the lower quartiles of median income levels. So these were our unadjusted outcomes in the CABG group. So patients with opioid use disorder did not have higher rates of in-hospital death. However, they did have higher rates of 30 and 90-day readmission, longer length of stay, and total hospital charges. We did not see higher rates of postoperative complications. Moving on to the valve surgery cohort. Patients with opioid use disorder similarly did not have an increased rate of in-hospital death. However, they did have increased 30 and 90-day hospital readmission, longer length of stay, higher hospital charges, and they were also found to have higher rates of certain postoperative complications of interest, including acute kidney failure and stroke. And these were our risk-adjusted outcomes according to opioid use disorder status. So patients with opioid use disorder in both groups had higher odds of 30-day and 90-day readmission, longer length of stay, higher hospital charges, and higher odds of acute kidney failure and stroke in the valve surgery group only. And again, we did not see higher odds of in-hospital death in the study. So there's multiple points of discussion from our study results. Given the current opioid epidemic, it's increasingly important to study the outcomes of surgical patients with opioid use disorder. We also found that the prevalence of opioid use disorder in the surgical population is comparable to that of the numbers that we're seeing for the general population. Surgical patients thus need to be screened for opioid use disorder. And the main findings of our studies was that present on admission, opioid use disorder is associated with worse postoperative outcomes. And these include, again, higher rates of mortality and hospital readmission, and also more complicated and more expensive hospital stays. And unfortunately, the perioperative management of patients with opioid use disorder is often challenging. These patients are at high risk of experiencing severe postoperative pain, And patients who receive inadequate analgesia tend to have worse outcomes and are actually at risk of exacerbating their opioid use disorder. So it's important to account for the patient's physical tolerance of opioids and to continue their baseline opioid dose and to up-titrate that dose rapidly as necessary because they have tolerance to the usual doses that we give to patients. It's important to not withhold opioids, but to taper them promptly once the acute pain resolves. So the current recommendations for perioperative management for patients on chronic opioids include consulting the acute pain service and or the substance use disorder service, whichever is available at the institution. To utilize neuraxial techniques, epidural, combined spinal epidural, spinal, and also regional anesthetic techniques like peripheral nerve blocks whenever possible. And also to use adjunct pharmacologic therapies when possible, which includes NSAIDs, acetaminophen, anticonvulsants such as gabapentin, pregabalin, ketamine, IV lidocaine, etc. Utilization of PCA can also be important in these patients. So importantly, opioid use is a modifiable risk factor. Excluding the situation of emergency surgery, there's often opportunities to address the patient's opioid use disorder weeks or months prior to surgery. And preoperative opioid dose reduction has been shown to decrease postoperative risks. Some institutions have implemented a perioperative pain clinic in order to decrease the patient's opioid use prior to surgery and plan for perioperative pain management. And lastly, medication-assisted treatment, or MAT, is an effective yet underutilized treatment for opioid use disorder. Some studies indicate that as low as 10% of patients with opioid use disorder actually receive this kind of treatment. And basically, it's a combination of behavioral therapy and medications to treat opioid use disorder. And these medications include methadone, buprenorphine, and naltrexone. And MAT has been shown to be quite effective at reducing mortality and opioid use, as well as easing cravings, enhancing treatment retention, and avoiding opioid withdrawal. So this slide just highlights the mechanisms of the MAT medications, naltrexone, buprenorphine, and methadone. And the type of medication that's to be used is dependent on several factors, including the state of the patient's withdrawal. Withdrawal from opioids should be fully completed before naltrexone or an opioid antagonist is started. Methadone, which is a full opioid agonist, and buprenorphine, which is a partial agonist, can be started for patients who's currently using opioids or has not yet completed withdrawal.
Yes, she's already cleared. Oh,
so these are the limitations of our study. So our results are dependent on accurate clinical documentation and data collection, and so any errors in that can impact our results. And additionally, we identified patients with opioid use disorder by preoperative diagnosis. So again, we're dependent on accurate coding, and we may thus be under or over-reporting their number of cases. Our database did not have data past 2014, so we may be missing data that may reflect more recent developments in the opioid crisis. And finally, our data set did not allow us to track postoperative opioid use. However, past studies have found that patients with preoperative opioid use have increased postoperative opioid consumption, they're more likely to be discharged with opioid scripts, and have a higher need for an opioid refill. So the following were the conclusions of our studies. Preoperative opioid use disorder is associated with worse outcomes after surgery. Opioid use should play a role in the preoperative risk assessment of surgical patients. And finally, further research is warranted into the optimal perioperative management strategies of this patient population. Okay, so I'd like to turn this over to Rob, if you're still here.
Hi, can you guys hear me? Yes, no, hopefully?
Yes, we can hear you, Rob.
Okay, sorry about that. I'm at the Alexandra Cohen Hospital, and a lot of the computers did not have speakers or cameras, as I found out. Just want to present the next steps. I think we're going to have to still use the PowerPoint that you're using, whoever's controlling it, and then just whenever you feel like it, you could just advance.
Yeah, sorry, let me go back to that slide.
Sure. I just wanted to reiterate what Alina said. Most of our previous research into these opioid use disorder patients was with using administrative data sets and big data. So there's a lot of inaccuracies with the coding. However, HCUP, who organizes these data sets, does have statistical briefs and feels pretty confident in their ICD-9 coding of these opioid use disorders or alcohol use disorder. So we feel pretty confident. And like most big data studies, we feel that any inaccuracies or misattribution in the coding should bias towards the null hypothesis. So we feel confident in our findings. The big limitation of our studies is that the administrative data sets do not have the amount of opioids used preoperatively or other medications used preoperatively. And we also do not have information regarding dosing, which most studies highlight that higher doses of opioids at discharge is more likely to have the patient using opioids post-discharge. So those are, I think, the two big limitations. Just to refocus this and reframe it on opioid use disorder, a big quality improvement initiative in the Department of Anesthesia is the reduction of opioids and the prescription of opioids post-operatively, and the use of ERAS, or enhanced recovery after surgery protocols in doing so. Anecdotally, when I was an intern, we used to regularly prescribe, after an appendectomy or cholecystectomy, about 96 Percocets for patients to go home with. About 8 pills a day for 12 days or so. I don't think that anybody would be prescribing that much medication now. The big issue then was that the surgeons did not want to receive phone calls to their offices about patients being in pain. Those are no longer concerns with the opioid epidemic and with the fact that most people were storing the opioids and all of the negative consequences. So I'll talk now about the use of ERAS protocols and how we feel that this is an effective and efficient way to reduce opioid use postoperatively. Next slide, please. This was the position statement from the Society for Obstetrical Anesthesia and Perinatology, and you'll find many similar statements from the other anesthesia, surgical, and perioperative groups that basically perioperative teams should utilize multimodal analgesic strategies as a way to reduce opioid requirements. And this pertains to cesarean delivery. But for most surgeries, there's increased use of non-opioids such as NSAIDs and or Tylenol, regional blocks like Alina mentioned, with the reduction in the use of oxycodone and Percocet. And then, like most recommendations, to use the smallest amount of opioids as necessary and only when needed as a rescue medication. Next slide, please. So ERAS stands for Enhanced Recovery After Surgery, and these are standardized perioperative procedures and practices that have been found to improve patient outcomes, such as early mobility, early urination, gestation, gastrointestinal movement, bowel movements, walking, and minimization of opioids. So the big things are to improve mobilization, limit IV opioids, increase use of multimodal analgesia, reduce in-hospital opioid use, and decrease opioid use after discharge. These are some results from Weill Cornell Medicine looking at our obstetrical service, and these are after cesarean deliveries. We implemented the ERAS protocol in 2017 by changing the order set. So we simply, in the computer Allscripts order set, highlighted the use of non-opioids and de-highlighted the use of opioids. And I believe the next slide should show that after we made this simple computer change in terms of what was being ordered as first line, second line medication, there was a reduction in the use of opioids. Next slide, please. So I believe this is it. And this is basically showing the reduction in the use of opioid tablets from when we implemented this order set change to September, about a year later. This is a hopeful slide that we are seeing that we may have peaked in the opioid epidemic in 2016, 17, 18, and we may be starting to come down from the peak. Unfortunately, the peak is pretty high, and we've all gotten used to looking at these curves with coronavirus and everything, and we understand and recognize the fast uptick and the slow downtick and plateauing off. And this quote, the decline was due almost entirely to a dip in deaths from prescription opioid painkillers, the medicines that set off the epidemic of addiction that has lasted nearly 2 decades.
Oh, and this slide was just to highlight that the COVID pandemic is compounding the challenges of the opioid crisis, and reports from national all the way to local media suggest that there have been increases in opioid-related mortality, particularly from synthetic opioids during the COVID pandemic.
And I think a little bit of this plays into one, patients weren't as able or easily able to get to their chronic pain doctors or their primary physicians who prescribe medications or perform procedures, physical therapy, everything like that was shut down, as we remember, in March, April, a little bit May. And I think this also plays into the fact that the opioid use disorder is one of these diseases of despair, and it's more about how people feel about themselves versus their actual economic standing. It's their feel for the future versus where they maybe are now. And I think the COVID pandemic, we could all say, raised a lot of anxiety and stress, depression levels throughout the country. And unfortunately, it's continuing until today.
These are our references. And we would like to thank the following people who have helped with these projects over the past couple of years. And thank you for your time and your attention. I'd like to open this up to any questions that any of you may have.
Again, I would like to apologize that for my computer issues at the beginning, but I think I left you in more than steady hands with Alina, best resident, great person to do research with. Hopefully goes to Weill Cornell chronic pain.
Thank you.
Hi, everybody. This is Chris Gonzalez. I'm the Health Equity Research Fellow. And I actually had a question. I mean, thank you for your presentation, and thank you for obviously pretty much focusing on this issue, which is obviously of great importance right now. I actually had a question to something that was mentioned early on in the presentation about the kind of like racial and ethnic proportions of the sample that you were seeing. It seems like there was a kind of different racial proportions depending on the surgical like cohort, and I was wondering why you thought that you saw those differences.
I am sorry. Do you want to go first, Alina, or should I? Okay. I am just making this up. I'm trying to come up with mechanisms to try to figure this out based on other readings that we've had. Yes, there is a big racial difference in the cohorts. I believe that the appendectomy, cholecystectomy, the abdominal surgeries were mostly Caucasian patients, whereas the heart surgery was mostly African American Black patients. I think because the valve surgery is more related to endocarditis, so there may be some racial factors in terms of what opioids are being used, if they're oral form or if they're intravenous, and if they're intravenous, if that could lead to higher rates of endocarditis. And a lot of recent studies have shown that association with presentation for valve surgery because of endocarditis and intravenous opioid use. Whereas I think that the abdominal surgeries aren't as heavy in the intravenous use, and that's more of the oral oxycodones, like Tylenol 3, so you don't see that. I think it's the mechanism of opioid use plays into it, and there might be some racial factors with that. That's not 100% explanation. I understand that. It's just a hypothesis. Not really sure.
I was going to say the same.
Thank you.
Are there any other questions? Okay, guess not. So thank you again, everyone, for your time and attention. And please let us know if you have any other questions about this topic.
Thank you again also, and thank you, Alina, once again, and hope everybody has a nice weekend. Thank you.
Thank you.